Good evening, friends. Thank you, Dr. Albanslal, for inviting me, including me in your beautiful course. I will be sharing my some videos regarding the management of Intumescent cataract. The Intumescent white cataract is a morphological diagnosis where the cortex swells up. So that's why the AC becomes shallow and intralenticular pressure, it goes high. This is very important. The most important to take the precautions because of this high intraocular pressure. And there is always a fear of extension of axis. You can see that, and their axis is extended. So the debulking is must. And how to do debulk? There are options. Either you do the capsulotomy 30 minutes before, IAC capsulotomy, and make a little small opening, allow the fluid cortex to come into the anterior chamber, and then take the patient. Or else, on table you can puncture the anterior capsule, allow the milky fluid to escape, and there is a Mohanrajan technique, very good technique. Then we have modified our technique also, and there is an orange pill method too. You can see here, very old video. We didn't have much knowledge about the management, but however, we would know at that time that the pressure has to reduce so that to avoid the extension. This is the Mohanrajan where he is using Venturi system, 500 vacuum, straight tip, and he would do that. See, the fluid has come into the probe, and there is a little small pit into the anterior cortex too. This is our technique. What we do here, that I am holding the main surgeon is holding the needle, sharp 26 gauge needle attached to two cc syringe, and that syringe is held by the assistant, and then after staining, make a puncture, and then the fluid is allowed to be sucked into the syringe. You can see here. The intralenticular pressure is already reduced. And now put the visco from the chamber and do the raxis. Now you can do the controlled raxis. However, because of if the capsule is thin, you must take precautions that it should not extend to the periphery. This is the last scene. The Freco procedure here, once you do the raxis, there is a very little peripheral cortex, no epinucleus. So there is no need for hydro. And the routine phaco, what you do, but however, you have to have the lower parameters. And because there is no epinucleus, you have to be very careful to avoid the PCR. You can see here there is a white intumescent cataract. I'm trying to aspirate the fluid. The raxis has little become irregular, but I could remove the fluid, and so the intraocular lenticular pressure was reduced after putting good visco, forming the chamber, and then you can do the controlled raxis. You can see these are male 48 years, so I'm expecting the cataract is intumescence really, no hard nucleus. And even without hydro, you can rotate the nucleus. And making the trench as usual. This is my choice of doing the direct cracking. If the nucleus part comes little anterior to the iris, don't worry about it. it may have, you have to go and inject in the visco. But if your probe goes near to the posterior capsule, then you can end up in problem. See, once it is done, you find a very hardly little cortex. It can be aspirated. And you can put the lens. Sometimes it is safe to make a very small rhexis. This is and then after doing the phaco, you can enlarge it. You have to be a little careful while doing the phaco because the opening is small. But once it is done, you can enlarge the rhexis. As usual, you have to be very careful. It should not extend to the periphery. Then, one more. This is interesting video I would like to show. Okay. Just 1 minute.
By the time he is finding the video, I'll just make 1 or 2 comments. Normally, whenever I am operating these type of cataracts, yeah, you got the video?
Yeah.
Yeah, go ahead.
So you will see it. I'm trying to aspirate the fluid. And inadvertently, you can see the rhexis is already enlarged. But then you have to be very careful because I was in the safe limit. It didn't go to the periphery. And once you complete the rhexis, as usual, same, do the phaco. There is one point which we should remember that at times, suppose there is a central posterior polar cataract along with this, maybe then in that case you have to be very careful that by chance you should not open the posterior capsule. So this is how it's done. Thank you very much, sir. Thank you.
Shroff, for wonderful presentation. One change what I do is I normally, of course, he is also not doing any hydro procedure, but he is trying to rotate the nucleus. I do not rotate because I want the stability of the nucleus for trenching. So I keep it that way. Only after trenching I rotate. Secondly, routinely what I found, the side port incision leaks a lot. Because for irrigation aspiration we want little bigger port and the chopper is thinner. So now in all cases, routinely, initially I used to do only for a hard cataract when I was using higher setting. In all cases, when I am going to remove my last fragment, because I don't have to chop now anymore, and I remove my chopper from the side port, so leakage is stopped. And if by any chance the posterior capsule is floppy, you will see because of the zonular weakness, sometimes the posterior capsule you can see the crumble. Or whenever the nucleus is very large in a mature cataract and a hard cataract, because it stretches the posterior capsule a lot. So in these cases, you may have to inject the viscoelastic to push the posterior capsule back before removing the last fragment. So as long as the nucleus is inside the capsule of fornices, it holds the posterior capsule back. Once the last fragment has come out, the posterior capsule will have more tendency to come forward. And even if the granules are weak, sometimes because of granule dehiscence or something, you might even ask your assistant to keep on injecting the viscoelastic. You feel the posterior capsule is too floppy and every time it is coming. So at that time, I will rather a little bit compromise on the cornea, put on a viscoat if possible, if you can afford it, patient can afford it. Then otherwise, even at the last fragment when I am removing, if I feel the posterior capsule is coming towards the port, I'll rather come closer to the cornea, let patient have a little bit of corneal edema which is settled down, than trying to compromise on the posterior capsule. And in a smaller pupil, whenever you use the capsular hooks, normally when we make a side port incision for chopping, it is corneal, because it's a corneal because we don't want the conjunctival chemosis. If we make a limbal incision, fluid will keep on coming and will cause conjunctival chemosis. But when you are putting the iris hook, you don't want iris to get lifted up. So your incision could be more limbus and you are not going to do the irrigation from that side, so there will be no conjunctival chemosis. So more the limbal incision, iris will be pressed down. And secondly, more posterior incision. Secondly, our aim is that the internal margin of the pupil should be beyond the incision line. That means your internal lip, this is from where the iris is going to collapse. If the pupillary border is behind the internal lip, then iris is not going to collapse. Your phaco tip is not going to rub. So you can make, like Rajesh Sinha was showing you can give a 5 hooks, or you can make a trapezoid incision. That means the incision closer to the incision, the hooks you can place them closer, and away from it you can place them wider. And so that if they are closer, they will pull the iris and pull the incision behind it. Same thing if any time iris starts collapsing in the middle of the surgery, whether it's a side port or a main port. If it is a side port, then you can change the side port. Leave that side port, make another very small side port which is more corneal than limbal, and so that it won't collapse. But if it is on the main incision, then you can put again 2 hooks just adjacent to the main incision, so that you can pull the pupillary border towards the periphery and it is not collapsing. But you place too far off away, it will still keep on collapsing. Keep on putting in viscoelastic. Do hypovolumic phacoemulsification in these cases. That means not most of the fluid should keep on going, and try to press the capsule against the anterior, iris against the anterior capsule. That means when you are not doing any phacoemulsification, keep the flow little up. Don't keep it at the iris plane. When you are doing nothing, so that it presses the iris against the capsule, not that you do underneath the iris and it keeps on billowing up. Any other comment you would like to make on any other technique or something you would like to give the message?
Yeah, we actually had a discussion while you were away, sir. But the last segment of intumescent cataract. See, you would find intumescence of 2 types, and usually it is a perinuclear intumescence that happens both on the anterior and the posterior fronts, but it is not unusual to find a pure posterior intumescence. It's rare, but it can happen. So in those cases, what will happen is, after you conclude managing the nucleus, you may find certain milkous substance in the anterior vitreous cortex floating. So that has already percolated the posterior capsule and gets deposited there. Most of the time you can leave it alone and it doesn't produce any postoperative inflammation. However, if you have it in your hands and you do trust your skills, then I would recommend that you go through the posterior capsule, clear some amount of superficial vitreous cortex, and along with take out the milky cortex so that it doesn't leave any opportunity for a phacoanaphylaxis to happen in the postoperative period. That's it.
So I normally will not do, I will not be so adventurous, and probably you have to have a pressure of finishing of the list also. But only thing, sometimes you may get confused whether there is a PCR or not. So whenever you see the opacity behind, so you may get panicked, have something drop. So if you see the donaces are the movement of this over there will be very slow and moving like this. So you have got to be very careful when you see it. Initially, when I used to get doubtful what is happening, whether I have ruptured the posterior capsule. So you got to be careful and make sure that it is not the rupture, but it is the donaces of the vitreous with along slowly and slowly some opacities or some the fluid is moving around. So diagnose it well. Then if you want to leave it, you can leave it as such. Or if you want to remove, as he is saying, if you have got the guts to go and rupture the posterior capsule and remove it, otherwise I'll prefer to leave it as such instead of doing PCC.